so the last thing I'm going to talk about is probably the thing that's more common, but maybe not as severe. So remember we talked about food intolerance and food allergy. So I'm going to talk more about feeding tolerance and just an overview and looking at the use of like Total Comfort, a product that has, low in lactose and partially hydrolyzed. So why do we even have tolerance formulas? So when you look at parents, they're concerned, my baby's fussy, they're gassy, they have diarrhea, they're not growing well. And a lot of the concerns from the physician are the same. They want the infants to tolerate it. They want to make sure it meets the needs of a rapidly growing infant and has all the nutrients that they need. One of the physicians said the most important thing he thought of a tolerance formula is he got less phone calls after the babies were on it. Because as a mother, a parent, you're going to be concerned if your baby has tolerance issues. So again, when you look at the spectrum, we look at the tolerance as being, especially from a physician point of view, it's a little lower where you change the feeding, you look at symptoms. The symptoms are spit up, stool consistency issues, gassiness. The more severe where the, our concern is really, is it intolerance or is it allergy? So then you're really looking at the symptoms of food allergy, the ones that I talked about before. So that's kind of the spectrum when we look at tolerance formulas, starting from that point to, amino acid based formulas. So it's very interesting when we looked at a study, and I think it was over 5,000 parents we looked at, and this was done globally, so it wasn't just in the US, it was all across the globe. And 2/3 or 66% of the infants reported that they had some intolerance issues between 2 and 4 months of age. So when you look at it, a lot of it could be also, children that have recurrent infections where they're placed on antibiotics. There's a whole host of reasons why they have it. But the most common complaints, and this is from mother reported, are colicky symptoms, constipation, spit up, fussiness, and diarrhea. So when we look at it, we look at the components of the diet. How do we change the carbohydrate, fat, or protein that may help with these tolerance issues? So we look at tweaking all of them to help improve tolerance. So again, when you look at it, the most common thing parents complain about, and I probably don't have to tell this audience about it, my baby's constipated, they have trouble passing stool, or it's the stools are too loose. One extreme to the other. So when we do our studies, when we do tolerance studies, our main outcome measurement is mean rank stool consistency, because that's kind of the measurement of tolerance. So really when you look at it, and also you ask these same parents what is attributed to, when they have symptoms, what's it attributed to? You can see over 60% of the parents that had a baby that was constipated said it's because of the formula, right? The diarrhea, you do have it, but it's only about 24% or whatever. But constipation is they will switch formulas more often if their baby is constipated. So when we look at it as well, you have different stool characteristics, as you know, if a baby is breastfed versus formula feeding. So when we look at it, what's normal? And when we do these studies, we talk way too much about baby's poop, of course, and we have diagrams and we have pictures because what is normal? You want it so it's somewhere between 2 and 3, right? So they're soft, and that would be normal for infant stool consistency. So when you look at protein sources, so when you look at standard protein, where the protein's all intact, then you look at partially hydrolyzed. So when we look at tolerance formulas, not allergy formulas, but tolerance one, they are just partially hydrolyzed. So a little easier to digest. You have peptides that are still longer chain, but the protein has been cut up. as opposed to extensively hydrolyzed or amino acids, which are used for treatment of allergy. So when we looked at it, and the formula in the Total Comfort is actually hydrolyzed whey, and again, we were looking at tolerance to make sure stool characteristics were appropriate. So when we looked at it, our primary variable from the study was mean rank stool consistency, which is where we want it, somewhere between 2 and 3, so 2.5. And parents, then we also have them rate it, and 92% of the infants that were on the formula rarely or never had stools that were too hard, and less than 1% that they were hard. But the main difference, or one of the main differences also for the stool characteristic, is the fat that is in there and how the fat is done. So years ago, and in some other formulas, the fat source is palm-oil. And the reason it was palm-oil was 2 reasons. Palm-oil oil was cheap, and as well, when you look at breast milk, the source, the largest amount of fat in breast milk is palmitic acid. But the palmitic acid in breast milk is very different than what the structure is when it's in formulas. So when you have a palm-oil oil, it leads to a firmer stool, and it also affects calcium absorption. So a little bit when you look at the position, so when you look at breast milk, the palmitic acid is on the, we call it SN2 position, so it's on the second position, and it's well absorbed. When you look at formulas that have palm-oil, the palmitic is on the S1 position, and it's not as well absorbed. So when you look at it, and why you get calcium soaps, is if it's not absorbed, it combines with calcium, and then you have calcium soaps, and you have decreased absorption. So again, we looked at feeding tolerance to look at this issue, not only feeding tolerance, but also bone mineral content. So we looked with comparative formula, and didn't have pre or probiotics also, and we didn't have pre or probiotics at that time. So really we were trying to look at the difference of the fat source on it. So it's a randomized trial. We also assess growth and tolerance during this. So really what we're looking at is stool characteristics. So again, they were, we're where we find ideal, somewhere between 2 or 3. So it was significantly lower in those formula when they were on the Total Comfort. And as well, we looked at bone mineral density. So bone mineral density was higher on those on Total Comfort on the formula that does not have the palm-oil. Also looking at vitamin D, and our vitamin D was slightly higher at 56 days as well. So what about carbohydrate sources? So then again, with lactose intolerance, when you look at it, really primary lactase deficiency is very rare in infants. It may be more common later on, but really it is rare in infants. The main thing that you need a restricted lactose formula for in infancy, kids that have infection, rotavirus, malnutrition, those type of things are where lactose intolerance comes up. So, symptoms of lactose intolerance, they just may have bloating, they may have abdominal pain, diarrhea. So, and it's usually the amount of lactose. Some even that have lactose intolerance can tolerate a small amount, but larger amounts give them difficulty. So, and again, and this is the one working in pediatrics that you found quite frequently, is because you could get it with sick children that had small bowel overgrowth, persistent diarrhea where you're wiping out the lactase, GI, gastroenteritis, antibiotic use, chemotherapy. Any insult to the gut can give you a problem with the lactase, because really it's right on the breast border, so it gets wiped out pretty easily, post-infection, post-antibiotic use. so that then they have the lactose intolerance. So a question we get asked quite often though, is that a problem because breast milk has lactose, and what is this, you're putting infants on a low lactose? But when we look at it, there's years of history on soy-based formulas which are lactose free. They've been studied for years without any problem. And low lactose formulas nowadays are really fortified with the amount of calcium, the amount of phosphorus that they need. And glucose is what we ultimately use as an energy source anyway, so it's not a problem to have it. There's also been some studies with comparing the two sources. Growth's been saying there's actually increased tolerance with a low lactose compared to a lactose containing formula in a lot of children. We have centers in the States, not that I agree with it, but their starter formula is the Total Comfort. If a mother's not breastfeeding, they don't put them on the standard ones, they put them on this to eliminate the tolerance issues because they have to deal with them so much. The other thing is with our carbohydrate source, so what we have some sucrose in it as well. So it's not only just the maltodextrin, we have a combination. So it's two reasons we kind of do that. Palatability. Is palatability for mom versus palatability probably for the infant. But when you have hydrolyzed formulas, they have this kind of beany taste. It has this, more of a bitter taste. So it helps with compliance when you have a bit of sucrose. As well, you have a dual carbohydrate system. So when you look at pure glucose, it is active transport across the GI tract, but when you have some sucrose, you actually have a facilitated kind of diffusion. So this unique blend has actually been shown that it may actually help absorption and minimize the risk of malabsorption when you have a dual carbohydrate source. The other thing we have added to the formula is also prebiotics. So prebiotics like GOS or FOS, we have galacto-oligosaccharides in the formula. They're not digested by the human enzymes, and they're fermented to produce short-chain fatty acids. It helps, as much as anything, what it really does is it really helps with leading to softer stools. And that's part of the reason prebiotics are put in formulas, is because they help with stool consistency. Excuse me. So again, they're known as food for the good bacteria. So for lactobacillus and bifidobacter, but it's dual source. So you're going to help feed the good bacteria and as well help with softer stools. And again, we've studied this to look at this and looking at feeding tolerance again in growth when we added this, because initially when the product was on the market, we did not have a prebiotic there. So our competitor actually had a higher amount. We put a lower amount because we already had really good stool characteristics. We were worried if we were going to, go too high on this. So again, it's a growth intolerance study where we follow these infants for 4 months and we look at weight, height, and tolerance. So there's no safety concerns for either formula. Mean weight gain was the same, no problems. It was against both formulas. But when we look at it, we do see that our stool consistency for the first 84 days was a little bit better, a little softer stools than the competitor. By 4 months, though, there's no difference. By 4 months, even though we recommend that infants shouldn't be starting foods till maybe a little later, it's hard to determine at that time. They're being fed pablum, they're being fed some other food by 4 months. So really, they were thinking the stool consistency difference because they had higher amounts of prebiotics in there, probably are to the presence of palmolayan that really is the main factor for the stool consistency. So additional also nutrients we make sure we add is similar to our other standard formulas. We add nucleotides. They're important for promoting gut health and supporting the immune system. We also supplement DHA, ARA, lutein. We're doing quite a bit with lutein and doing some basic science research with lutein. It's been found now that lutein is a really powerful antioxidant. So when you combine lutein with DHA, they co-localize in the brain, and there's an antioxidant protective effect on the DHA in the brain. So a lot of times we're looking also at the combination of vitamin E, DHA, and lutein to actually help. So the lutein helps with eye development, but as well, it really helps as being an antioxidant. So again, the system is a partially hydrolyzed whey. It's very low in lactose, 98% free. We have a prebiotic galacto-oligosaccharides. Again, DHA, ARA, lutein, GOS and the nucleotides to help with the immune system, and also the oil source being palmolain free to improve bone mineralization. So the question quite often we get asked, and there's a real controversy in the field, is what about these formulas for cow's milk allergy in the prevention, not the treatment, but in the prevention. So there was a large study, the GENIE study that was done in Germany, that found that kids that were on both extensively hydrolyzed and partially hydrolyzed, not in all allergies, but they did have a reduction in atopic dermatitis. So this is a Middle East consensus statement that came out in 2014, and they're saying if they're not exclusively breastfed, you could use either extensively hydrolyzed, which I realize isn't available, or partially for prevention of allergy in high-risk infants. It's an area in the field that there's controversy, though, because when you look at the GENIE study, they weren't exclusively fed on partially hydrolyzed formula. Most of those children, or a lot of those children, were breastfed as well. So was the breastfeeding what was protective, or was it the formula? And the extensively hydrolyzed actually worked a bit better, but it's something that in the allergy field people are really talking about, because you asked what about high-risk infants. So, would you use something like that? Is it going to be kind of protective? It's only found to be protective for atopic dermatitis, but also there should never be confusion that it can be used for confirmed cow's milk allergy, because those children will react. Questions? Thank you for your attention. Yes?
I want to thank you for all this valuable information first.
You're welcome.
My question is, I think now we see infants with diabetes mellitus. So we ask ourselves, what's the proper milk? And if we give the ordinary milk, then it will need too much insulin. So, is any special formula for that?
There's no special formula out for children with diabetes. I mean, part of it is you want to make sure that they're not fasting, feeding them frequently. I mean, it's a normal diet that has the normal amount of carbohydrate, fat, and everything. There's not a specific carbohydrate when you look at infant formula that's recommended. And even as kids get older, there's some feeling that cow's milk, not cow's milk formula, but cow's milk, because diabetes is an autoimmune disorder, does cow's milk have some influence in diabetes? It's an area of controversy. Most still when you look at management, do not do anything as far as treatment. I mean, the best you can recommend is using breast milk for those children.
Thank you very much.
Yes.
Thank you very much. Actually, very useful. Very useful. 3 mini lectures. I have 2 questions. One about the use of soybean-based formula in areas with high incidence of G6PD or high prevalence of G6PD deficiency.
Right.
So, what do you suggest? Would you suggest that we test infants for G6PD level before we start? This is
Because you have a real high incidence
yes, we
of
do.
them.
Yes,
Right.
we do.
So, in the Association for G6PD, what they're saying is except for fava beans, you don't need to do any other restriction. Now then there's an article that came out that talked that soy, and depending how the soy is broken down, may be contraindicated, right? So I'll find that article because I found it so interesting because all of my career we said, except for fava beans, don't worry about it, and certain medications. But now there's an interesting article that was done, and it was done in the Middle East, and it looked at all these patients with G6PD, and there was intolerance to soy.
I think according to the level of the enzyme,
Yes.
we have some great, very
Right.
wide levels of
So
enzyme.
very severe mutations may have a problem with soy. A lot of the other ones won't have a problem. But I'll get that article because it changed what I thought. I was telling people forever, don't worry about it, and then that article came out and went,
Then maybe we can recommend to do G6PD level before we start.
oh, to actually look at the enzyme level.
Soybean formula. Can
Yeah.
do this.
Even if I think something else, if we have a proper family history, we can.
Right.
So you get a proper history and examination for the family and the baby. Take the decision. So because we don't have here as a grocery test or when you're born on screen, we don't
Right.
put the 6PD as a level of screen. But if I have a good guide or strong family history, which is 6PD, patient in the family, so I can do it as a routine.
Right.
So just asking for and at least because our developing country. So still the cost benefit of the test.
Right, versus,
we have to all that to consider all these types of process.
Yeah.
My other question is that about the elimination, not about the elimination, the use of this comfort formula. Because if you are suspecting that there is an oxidative allergy, that you can use certain formula which is a bit low allergenic. However, sometimes now they start saying that even if you suspect allergy, if you start in the allergen in a small amount early on, you may help even delaying the development of allergy.
Although it's only really been shown, I mean, in studies with peanuts, right?
Yes, peanut allergy is.
Peanut allergy it has. So when one of the last allergy meetings I was at, it became clear that there really hasn't been that study with milk or soy. So is that sensitization, should it be done with infants that you suspect when you give them small amounts? I don't know what the answer is. It certainly is being done with peanut allergy, right? Where they give controlled small amounts and it may be helpful. I don't know with milk allergy. They haven't done it with milk allergy yet, so
We should do it.
yeah, I know.
My apple should do it.
Yeah, because there's more milk allergy than there is peanut allergy, right? So, yeah, I don't know the answer. That's an interesting question.
Thank you.
So, I have a small question maybe related to the second lecture. What is the youngest age or early age to diagnose cosmic allergy, and what is the oldest age? Because we in the favorite time, the last times we were talking about more than 2 weeks of age. We started talking about it, and usually it is get read from this allergy about 3 years of age. So does this still solid?
That's
or-
pretty solid research. I mean, one of the things you're not going to see allergies in a premature baby, right? Because their immune system's not developed enough to actually react. And they say 2 to 3 weeks is probably the earliest you're going to see. Yep, and up to about 3.
The problem here, we see some cases how newborn, because I faced it, I think yesterday or something like, or 2 days before, a baby coming with atopic dermatitis and this age is about 5 days and this diagnosed
Wow.
cow's milk protein allergy and forbid so and so. And just, is it 5 days of age?
That's young.
And
Just in my experience.
Is it a clue to consider a cow's milk protein allergy? So, or just under trial, because I find the mom come to me very frustrated. They forbidden her to take our dash of the pediatrician.
Oh, really?
I told her about the breastfeeding as dash.
Yeah,
In
yeah,
our
okay.
country. No, just joking, because they forbid, they give the mom sense of guilty, and they give the mom, we have to forbid him to take so and so and so and so.
Yeah.
And the mom is coming like that to me and frustrated and depressed.
Was there a family history in this patient?
No, not at all. But
No?
there's a very powerful history of allergy. So I consider this case as a case of allergy and atopic dermatitis, and I permit the mom to take feed as she's not. I consider I concentrate on breastfeeding, but ask not to eat everything. And
Oh, I see.
put, I put the formula aside, and then I get a proper history of the allergy in the family, and give her a week time, and I consider it. We will do a trial for 2 to 4 weeks to consider it or not to consider it. So is your point? Yes, I consider, but firstly, because the baby is 5 days of age, so this is a point, not 2 or 3 weeks. So I'm coming with atopic dermatitis like that. So give it, yeah.
Yeah.
So this is a question for that.
Yeah. That would be young. I mean, from but
What about the possibility of being anything else sort of uses online and uses
Even from Photoshop. Because I get this of Photoshop with the baby with the old Photoshop. So sometimes the old not the super LED lamps, the old Photoshop cause some sort of
skin rashes.
Skin rashes,
So that it's.
It can be something else.
Yeah, it can be something else that they're allergic to, the laundry detergent, to the skin lotion, yeah, whatever.
I'm sorry to say one of the famous consultants considered this point. And then they come to me, so I postponed it and asked to do a trial again and see what's happening.
Yeah.
Well, but still, not less than 2 weeks easily to diagnose cow's milk protein allergy.
What is the youngest age have you seen with cow's milk allergy in your career?
For 10 days.
10 days.
Part of it why you saw it then, though, and maybe it's clinical practice why you saw it, because babies get discharged and they don't come back in for their first visit till 10 days or 2 weeks, right? So sometimes you wonder, if you saw them at a week, would you see anything, right? But that was a family, high-risk family. You know, mom ended up being diagnosed with esophageal EOE disease. So she had taken inhaled steroids for GERD her entire life. She eliminated so many foods. She ate rice, lamb, like about 3 foods herself, but she never was ever diagnosed, right? And so with that, when they came in and that history was taken, that was about the youngest one I ever saw.
Was that baby breastfed?
Yeah. And it was a breastfed baby. But the mother had, we couldn't eliminate anything else. She didn't eat milk. She
We have
didn't.
Medicare.
Yeah. We didn't even have an amino acid based diet back then. I mean, there wasn't anything available.
So you have to choose either the all-free or the Medicare and Medicare.
So what that mother was put on, there was an amino acid based diet, this is years ago, that was used for GI disorders in adults called Criticare or whatever, and that's what we finally put the mother on, because this mother, I mean seriously, this mother made me look obese. She was just, so malnourished, poor color, just, I don't even know how she breastfed when we took the diet history from her. And so she had suffered her entire life, and just kind of got through it. She'd been on,
Really, Baba, thank you very much for
You're
this,
welcome.
very precious lectures and for the discussions. I do appreciate your presence. Thank you, Dr. Muhammad and Dr. Nawal, for all this support, and I hope this will be a continuous support. Especially, we're very happy with scientific support, and I get the opportunity even to do some sort of hanging for them to get the books.
Yes. Yes. Okay.
Yes, I will ask for the three. I ask for the 3 books. I think it is very important. It is a part of the society, our social activity, to have the family guide for the parents. So I think it is important to be as a routine in the clinics.
Food lists, the one that you said.
Food
lists.
Yeah, I mean, food lists unfortunately the food lists need to have more Arabic foods in them because they're based on, but a lot of the things are rice, the other things are